Welcome to my reflection on the Global Health Immersion experience in Geneva, Switzerland in May of 2026. This is Angela Coulter. I'm a graduate student getting ready to graduate with my MPH in Social and Behavioral Sciences. In this presentation, I reflect on what I observed, what I learned, and how the experience shaped my understanding of global health, population health, and my own evolving public health direction. This immersion took place in Geneva, Switzerland, during and after the 79th World Health Assembly. Geneva is one of the world's major centers for diplomacy, multilateralism, and global health governance, so it was an especially meaningful place to learn about public health on the world stage. My experience included attending 12 World Health Assembly side events, 6 presentations at the WHO, and several organization visits and tours. These included the Health Innovation Exchange, the World Council of Churches, the Global Fund, the IFRC, the International Museum of the Red Cross and Red Crescent, the United Nations, and CERN. We also took day or afternoon trips to Yvoire, Chamonix, and Annecy in France, which added yet another dimension to the overall experience. Being physically present in Geneva made global health feel much more real to me. Instead of only reading about institutions, policies, and negotiations, it was really amazing to be able to see the places where those conversations happen, be a part of the conversation, and better understand how interconnected these systems are. I came into this experience with a few clear intentions. First, I wanted to gain a broader view of public health outside the United States by learning directly from these global health institutions, organizations, and discussions. Second, I wanted to connect with others who had a shared interests in global public health. Third, as I prepare to graduate this summer, I wanted to explore how this experience might help shape my evolving career direction. This immersion definitely fulfilled these goals. It gave me broader exposure to global public health efforts and allowed me to connect with people who care deeply about many of the same issues that I do. As I am still shaping exactly how I want my career to evolve, this experience gave me more clarity, momentum, and direction. One of the most meaningful parts of the trip was the group itself. Our Kent State cohort included 14 students and guest students, along with 2 professors. There was a wide range of ages, professions, life stages, and perspectives, all represented within this group. That diversity made the experience much richer for me. People interpreted sessions differently, asked different questions, and brought different forms of personal and professional experience into the conversation. That made our discussions much more layered and thoughtful. The group dynamic also created a strong sense of shared learning and support. Geneva itself is an important part of the learning experience. It's a city shaped by diplomacy and global governance, and it serves as a home to many major international institutions and organizations. Because of that, the city made global health feel concrete and tangible. It's one thing to hear about the WHO, the UN system, or international negotiations in a classroom. It's another to be in the city where so much of that work is coordinated and discussed. Geneva made the scale, seriousness, and complexity of global health governance much more relatable to me. One of the things that stood out to me most immediately in Switzerland was the built environment. The walkability, the public transportation, and infrastructure were exceptional. It was easy to move around using trains, buses, and trams, and that made healthy daily living feel normal and accessible. To me, this was a clear lived example of the built environment functioning as a supportive determinant of health. This stands in strong contrast with the United States, where outside of a few major cities, this level of integrated transit and walkability is uncommon. It also helped make visible the connection between infrastructure and broader population health patterns. Switzerland's strong public systems align with this high life expectancy, strong population health, high living standards, and low preventable mortality. Experiencing this in daily life made determinants of health feel less theoretical and much more real. The regional visits to Chamonix and Mont Blanc, Ivoire, and NSC added an important dimension to the trip. Time outside of the formal sessions created space for us to reflect, connect, and gain perspective. These visits gave the experience more cultural and geographic depth. They also helped balance the intensity of the formal meetings and presentations. For me, they created opportunities to process what I was learning, connect more deeply with others in the cohort, and appreciate the broader regional context surrounding Geneva. My core reflection from this immersion is that global health is often limited less by lack of evidence than by political will, trust, and community-centered implementation. Across many sessions and meetings, it became clear that in many areas, the world already knows a great deal about what works. The challenge is whether systems are willing and able to act on that knowledge effectively. A second major reflection was that health extends far beyond disease. Again and again, the experience reinforced that health includes systems, power, environment, digital life, and social connection. This aligns closely with the WHO definition of health as a state of complete physical, mental, and social well-being, and not merely the absence of disease or infirmity. Across the immersion, several themes were consistent. The gap between knowledge and action, the role of politics in funding, the importance of trust and local ownership, the many categories of determinants of health, and the close interrelationship between climate change and health and well-being. One of the clearest themes was the gap between what we know and what we do. Effective tools, evidence, and strategies already exist for many major public health problems, yet action is often slowed or blocked by political barriers, donor-driven priorities, institutional inertia, industry influence, and weak accountability to communities. Examples of this came through in discussions around polio eradication, plastics and health, climate and health, and reproductive health. In each of these areas, the challenge was not simply discovering what works, but also getting systems, institutions, and leaders to act in ways that are sustained, equitable, and effective. This was an important reminder that beyond evidence generation, public health progress depends heavily on implementation, governance, and public accountability. A second major theme was that health is shaped heavily by governance and financing. Who sets priority matters. Funding structures matter. Political choices matter. This was especially visible in the discussions of WHO funding pressures, the US withdrawal, reform conversations at the World Health Assembly, and presentations from the Health Innovation Exchange and the Global Fund. Across these examples, it was clear that global health architecture is deeply influenced by political power and donor dependency. What stayed with me is that improving health outcomes requires attention to both interventions and the systems that decide which interventions are prioritized and supported. Trust was another theme that came up repeatedly. Effective public health requires listening, humility, co-creation, and shared ownership. Without trust, even technically strong interventions can fail. This was reflected in discussions about vaccine hesitancy, adolescent contraception, the World Council of Churches Safe Spaces model, the IFRC's community presence, and the Health Innovation Exchange's emphasis on listening before bringing solutions. One of the strongest takeaways for me was that the communities cannot be simply treated as recipients of public health action. Sustainable progress depends on real engagement, local voice, and genuine partnership. This immersion also broadened my understanding of the determinants of health. Health is shaped by far more than medical care. Again and again, sessions pointed to the importance of social, commercial, digital, environmental, political, and built environment determinants. Geneva and Switzerland themselves provide a powerful living example of this. The built environment made many of these ideas visible in daily life. At the same time, the formal sessions expanded my thinking about how health is influenced by corporate practices, digital spaces, policies, infrastructure, and social systems. This theme reinforced for me that population health must be understood through the wider systems people live within. Another major theme was the interrelationship between climate change, environmental conditions, and health. Throughout the immersion, climate change was framed as a core and emergent public health issue. Topics such as air pollution, indoor air quality, plastics, displacement, and conflict, climate justice, and humanitarian response made clear that environmental conditions shape population well-being and health. This was especially relevant to me because it reinforced my growing interest in the connection between climate change, well-being, and longevity. I was also impressed by how many global actors are already prioritizing this relationship, even if public understanding still lags behind. One of the most personally meaningful themes for me was the emphasis on social connection, well-being, and human dignity. Public health governance should value connection, belonging, dignity, and quality of life well beyond just disease outcomes. This came through in discussions of loneliness and social isolation, humanitarian systems, reproductive health and menopause, and the role of faith communities. These topics, which align with Blue Zone theory, reinforce the idea that public health must care well beyond whether people survive, but also about how people live, connect, and experience their lives. This aligns closely with my own interest in longevity, well-being, and community-centered practice. This immersion made my many MPH concepts feel concrete and interconnected. Social determinants of health were present everywhere, but so were health policy and management, social and behavioral sciences, environmental health, health equity, and epidemiology. What changed for me was seeing how all of these overlap in practice. Governance affects equity, communication affects behavior, environment affects well-being, policy affects access. These are all interconnected and work together. Several things surprised me from this experience. First, the fact that Switzerland makes determinants of health and supportive built environments so visible and easy in daily life was amazing to me. It was one thing to study determinants of health in theory, but another to be in a place where these things are so clearly reflective in transportation, infrastructure, and daily movement. Second, the cohort experience had way more of an effect than I expected. The people in the group really added depth, support, and perspective in ways that became a major part of the learning itself. Third, I was surprised by the urgency, realism, and willingness to collaborate, which was clearly shown by WHA event speakers, panelists, and the WHO leaders who seemed ready, willing, and able to address challenging issues. I was also pleasantly surprised by how strongly climate change and environmental issues have become prioritized within popular population health discussions. At the same time, I was reminded of how much public understanding still lags behind the evidence. Many people still do not connect environmental and climate issues to their own personal health experiences, providers included, and that remains a major barrier to action. Experience contributed meaningfully to both my personal and professional growth. It increased my awareness of the importance of communication, trust, and cross-sector translation of evidence. It also confirmed my personal interests in longevity, well-being, equity, and community-centered practice and communication. It gave me a broader exposure to the world stage of population health beyond the United States, which was one of my major goals going into this trip. And it helped me shape my aspirations for my evolving career direction. I'm still working that out, exactly what that path looks like, but this immersion gave me a stronger sense of where my interests and values are pointing. Looking ahead, this experience gave me several practical takeaways for my future work. I want to ground my work in both evidence and local realities. I want to prioritize trust, dignity, and cultural humility. I want to lead with listening. I also want to communicate in ways that are easily translatable to the individuals and communities most affected. That includes helping people connect public health evidence to their own lives in ways that feel relevant and understandable. Finally, I want to advocate for longevity and well-being in ways that start from the ground up, while continuing to keep the bigger picture of determinants in view. So finally, this immersion left me with some important questions. How can evidence be translated so people see its relevance to their own lives? Secondly, how can US-based public health professionals engage in global efforts despite current domestic political limits? And what does accountability look like at a global level when major powers, like the US, refuse participation? These are at the top of mind as I carry forward in my work. Thank you for listening to my reflection on this experience. The immersion really expanded my worldview, deepened my understanding of global and population health, and it really gave me some important questions and a direction to carry forward.